Welcome back. Now, from today, we are starting a new series as per the requirement of my students, that is case discussion. And this is the first prototype, and the topic is inguinal hernia. And for the preparation of this case discussion, I would like to thank one of my students, Surbi, who has submitted and helped me in the preparation of this video. And at the same time, I'll request all of you, if you are interested, you can also send me the history and examination part prepared by yourself regarding the topics I'll be posting here with the images, the options available, and you just prepare the slides according to your understanding. I will try to modify it if required, along with the insertion of clinical snaps, and that will be presented here in the form of a video discussion. Okay, my email ID, it will be shortly, you can see here as the first case discussion, and here is my email ID, shashank.mishra13579 @gmail.com. Okay, you can send your case presentation over this mail ID. Okay, let's start with this case study on inguinal hernia. And again, I would like to thank Surbi Saradna, one of my students, for helping me out. Remember, there is always a scope for improvement. So if you find any modification or any gap in this presentation, you can always write to me in the comment section. You're most welcome, and we will incorporate those modifications in the subsequent discussions. There is a method known as student-doctor clinical teaching method. Now, this video discussion is a perfect example of this method, but I would like to call it as student-doctor clinical learning method. Instead of teaching method, it's a clinical learning method. Mutual learning is being done and we learn together, right? So let's start with this first case discussion, prototype 1. Topic is inguinal hernia. Prototype means the patient may present like this. The basic structure we are discussing. So in history, chief complaints, a male patient of age 60 years, occupation by farmer, resident of Meerut, presented with a swelling in right groin since 1 year. I'm just reading out whatever is being presented by my student. Whenever and wherever it is required to modify something, I have done that. But still, if you feel so, you can comment. will incorporate your suggestions if that is applicable to this presentation. Now, history of present illness. The patient was apparently asymptomatic 1 year back when he started complaining of a swelling in right groin area. The single swelling initially appeared in right inguinal region above the groin crease and then extended into the scrotum within next 6 to 8 months. Mentioning the time duration is very important. Initially the swelling was small in size but then gradually increased. Swelling also increases in size with cough, the straining and lifting of weight. Swelling disappears on lying down position. There is no history suggestive of, this history suggestive of is important. Instead of writing history oblique O history of, just write history suggestive of. So no history suggestive of pain over the swelling or the associated abdominal pain. Negative history, there is no history suggestive of fever associated with the swelling, no history suggestive of vomiting, constipation, cough, difficulty in micturition, swelling on the contralateral side, and any other regions of the body. So here you can focus that most of the factors in the negative history like constipation, cough, difficulty in micturition, all these are associated with raised intra-abdominal pressure. Could be a factor for initiation of or appearance of this inguinal swelling. We must rule out the bladder outlet obstruction or any chronic abdominal condition leading to raised intra-abdominal pressure, right? In the past history, no history suggestive of hypertension, diabetes, tuberculosis, bronchial asthma. There is no history suggestive of any surgery in the past. These points, they do change our management plan of these type of patients. So these history points should be taken care of. The family history, there is no significant past history or family history contributing to this disease presentation. The personal history, the patient is moderately built, mixed by diet, means vegetarian as well as non-vegetarian, has a good appetite, the normal bladder and bowel habits, patient is taking adequate sleep, no known history suggestive of addiction like alcohol and smoking, and there is no history of any drug allergies. Now, the physical examination part. The general survey, the general examination, and the local examination, right? In general survey, the patient is sitting comfortably on bed, has fair appearance with moderate build and moderately nourished, and is cooperative. General examination, pallor, icterus, clubbing, cyanosis, edema absent, no palpable lymphadenopathy, temperature is 98.2 Fahrenheit, the pulse is 96 beats per minute, regular, rhythmic and normovolumic, blood pressure 130 by 80 millimeter of mercury, measured on right arm in supine position, The systemic examination, CNS, patient well oriented to time, place and person. Cardiovascular system, S1, S2 normally heard with no associated murmurs. Respiratory system, normal. Vesicular breath sounds heard all over the area. The per abdomen findings, on inspection, no scars and sinus present. Normal skin, palpation, no organomegaly, no mass per abdomen, soft and non-tender abdomen is there. On percussion, tympanic note all over the abdomen with normal dullness area over the liver. The auscultation, the bowel sounds are present. The per rectal examination, the significant findings are there is no fissure, no external hemorrhoids, no prostatomegaly with sphincter tone normal, and there is no luminal growth. Mucosa is smooth and finger not blood stained on removal. At least these findings should be mentioned, whether present or not, but at least we should mention these findings on per rectal examination, right? Now, the very important in this case, the local examination. On inspection, the right side, that is the affected side, a piriform shaped swelling of size approximately 10 into 4 centimeter, extending from above and medial part of right inguinal ligament down into the scrotum up to the upper pole of right testes. No visible peristalsis over the swelling. Skin over the swelling is normal. Cough impulse is present. Penis is in midline. In supine position, swelling reduced spontaneously. On the left side, the left inguinal region, the scrotum, the testes within normal limits. The palpation under local examination, all the findings of inspection we are going to confirm. No local rise of temperature, no tenderness. We cannot get above the swelling. This we cannot get above the swelling is very important. If we can get above the swelling, it means the swelling is purely scrotal in origin, as seen in hydrocele. But if we cannot get above the swelling, it is suggestive of the hernia, inguinal hernia, right? Inguinoscrotal origin. Its consistency is doughy and granular, and that is suggestive of the omentum. The content is omentum. The test is palpable separately from the swelling, both the sides. Ring occlusion test. We are standing on the right side of the patient or sitting on the right side of the patient as an examiner. Patient is standing, and on occlusion of deep ring with thumb after reduction of the content, we are placing our thumb over the deep ring, deep inguinal ring on the right side. Ask the patient to cough, but the swelling did not appear. The ring occlusion test. And Gman's test. In Gman's test, cough impulse in this patient is felt at right index finger. I hope you all know how to perform these tests. If not, we can again form another video for demonstrating or for explaining these tests later on. So Gman's test, the cough impulse is felt at right index finger. If the cough impulse is felt at right index finger, that is suggestive of indirect inguinal hernia, right? If cough impulse is felt at middle finger, right hand, that is suggestive of direct inguinal hernia. If cough impulse is felt at ring finger, right hand, that is suggestive of femoral hernia, right? So this is Gman's test. Then third one is finger invagination test. The cough impulse is felt at tip of the index finger or the little finger. Finger invagination test, right? Now on percussion, dull note over the swelling is present. That is again suggestive of the content as probably momentum. Then auscultation, no peristaltic sounds heard over the swelling. Again suggestive of the content could be possibly omentum, not the bowel. So our provisional diagnosis based on the history and examination findings is right, reducible, uncomplicated, incomplete, indirect inguinal hernia with omentocele, right? I would suggest all of you to write down your comments in favor what we have just presented here, the points in favor of this provisional diagnosis. And if any question, kindly raise it. Now, based on provisional diagnosis, the patient will look like somewhat this. You can see here, I have marked three regions here, first, second, and third. This first region is suggestive of the right inguinal area where the swelling is there, apparent here, and that swelling is coming out inside this right scrotal area, hemiscrotal area, denoted by the second arrow. And this is the third arrow. This bulge is basically the left side testes, right? So what we have discussed till now, the patient will somewhat look like this clinically. So first, the right inguinal area, the reason the bulge is there. This is ASIS. This is the right hemiscrotum that is enlarged, filled up with the content, that is possibly omentum, as per the findings what we have discussed. And this is the left side testis, separate bulge we can see here, appreciate here, right? So this was the provisional diagnosis. Right reducible, uncomplicated, incomplete, indirect inguinal hernia with omentocele. And this was the clinical picture. Now, just to include, suppose if the content is not omentum, it is small bowel, then what will be the change? Rest of the thing almost same. What is different is there will be visible peristalsis. There will be visible peristalsis, right? Over the swelling, cough impulse is present, and rest of the thing almost same, right? On inspection. On palpation, if the content is bowel, rest of the thing almost same. But when pressed, gurgling sound is heard, right? Gurgling sound is heard. Doughy feeling will not be there, granular feeling will not be there, rest of the thing almost same. All these tests, the same thing. Why? Because that is related to the content of the hernia, not the type of hernia. These tests, they are deciding what type of hernia is there. On percussion, instead of getting the dull note, we are having resonant note over the swelling. On auscultation, sometimes we may hear the peristaltic sound. These were the differentiating feature if the content is not omentum and the content is a small intestine. So our diagnosis would be in that case the right reducible, uncomplicated, incomplete, indirect inguinal hernia with enterocele. And based on this discussion, the second one, this could be the possible picture during intraoperative period. You can see I have marked 5 reasons here. The first one, the second one, the third one, the fourth one, and the fifth one. I will not tell what are these structures here. I will request all of you to identify these structures and write down your responses in the comment section, the 1, 2, 3, 4, 5 related to this picture, right? And then further on, will, depending on your comments and your feedback, will again proceed. So if it is useful, subscribe it, like and share to promote the learning process here. And any query, or even if you want to submit your case presentation, you want me to moderate the things for you, you can just send your work or presentation or your history examination part on my email. I'll suggest the various clinical topics that is available and you can choose any one from that on your WhatsApp group, right? Thank you and namaste.